It's my pleasure to welcome you here for this seminar. For those of you I haven't met, I'm Tony Janetos. I'm the director of the Pardee Center for the Study of the Longer Range Future. The center is structured around the notion that what we really need to understand in a truly interdisciplinary way are the broad array of forces that essentially cause the world to unfold the way it does over periods of decades out to a century. And we've defined that as including scientific elements, so elements of the environment, but also governance, politics, economy, and health. And I'm particularly pleased to open this seminar because this seminar is the result of one of the really fun programs that we do for BU graduate students, which is the Summer Fellowship. And I think Maia will talk a little bit about that process. But what we will discuss today is really the culmination of work that began several years ago and now has come to fruition. Before I introduce our panel very briefly, I do want to impart a little bit of administrative information. So for those of you who aspire to give one of these seminars, the Summer Fellows Program applications deadline is Monday, the 14th of March. This is open to all BU graduate students. About a month after that, back in this room, we will have our annual Distinguished Lecture, which this year I'm very pleased that we'll have Sir Robert Watson, Bob Watson, to talk about the interface of science and policy, and copies of the research report of Maia's paper are on the table near the door. They're also online on the center website, and so please help yourself to copies. That's what they're here for, you to take them away. That's what they're for. So before I go, let me just introduce our panel briefly. Professor Susie Foster from the BU School of Public Health and the Center for Global Health and Development will moderate the panel. She's been one of our faculty fellows at Pardee for many years and interacts a lot with students in the summer program. Professor and Dr. Franklin Huang, who is the co-founder of Global Oncology Incorporated. He's an oncologist at Dana-Farber and the Broad Institute. And then, of course, Maia Olsen is now a program manager for the NCD Synergies project at Partners in Health, and she's also volunteered at Global Oncology for quite a while, and she holds a Master's in Public Health from Boston University and is a former summer fellow. So with that, Susie's going to moderate the panel, so I'm going to turn it over to her.
Thank you, Tony. Well, welcome everyone. Really glad you were able to join. Shout out to HS 450. I know you have read the paper, which is going to be really exciting to hear what you have to say or questions you might ask. So we're going to be talking about a really interesting problem and an interesting initiative that's been working to address this particular problem of cancer in the low and middle income countries. So without further ado, and then so the program will be that first Maia will speak, and then Dr. Huang will speak, and then I will say some sort of concluding, summarizing remarks about the overall picture of non-communicable diseases in the low and middle income countries as a whole. So let's go ahead and get started with Maia.
Hi everyone, so I am Maia Olsen, and as Tony mentioned, I was a 2013 summer fellow while I was getting my master's at BU in public health. I came onto this topic a couple of different ways. I've been a global health and development nerd for a really long time and was really interested in sort of the macro level policy and advocacy. In terms of cancer, that came in a very different way. When I was a junior in college, I was diagnosed with Hodgkin's lymphoma, and so it was the first time that I had personally kind of encountered disease and that vulnerability in my own life. And it took a few more years, 2 or 3 more years before I put my kind of professional and student interests together with with things that had happened in my personal life. I was a student and a volunteer at a hospital in northern Cameroon, and I met a 9-year-old with lymphoma who was on a very similar treatment as I was a couple of years ago, and it was shocking how shocked I was by seeing cancer in that setting, and of course, kind of cancer, NCDs, diabetes, heart disease, all of those things happen in low-income countries as well, and it's very neglected in terms of funding, policy advocacy, and so that was my interest area. I included this slide a little bit tongue-in-cheek. Cynthia asked us to do a survey really recently talking about kind of our experiences with the fellowship. It was to a bunch of alums. I included this slide in case there is anyone interested in the fellowship. It's a really, really wonderful program. One of the questions that tripped me up was kind of, did your research change over the course of this? And I was like, no, I always knew what I wanted to look at. And I pulled up my application, actually, and I had said I was going to come in and review every possible opportunity and barrier that low and middle income countries face in cancer, which is not possible for anyone, let alone an 8-week fellowship. And so as I was going through the first weeks of the program, I was really inspired by peers who came from a number of interdisciplinary backgrounds to look at the question that I found really fascinating at the time. I had done a lot of early work in HIV/AIDS, and I was curious how they did what they did. Why was the global AIDS movement so successful, and what lessons could be learned for other disease areas and other big issues? Did the paper, finished the fellowship, and then I got a job in the field. And as Cynthia and Tony know, it was a bit of a process, kind of rethinking some of my arguments as I got to be in rooms in Geneva and see kind of how the work happens outside of the classroom. So I'm not going to spend very much time on this. This is all in the paper if you've taken a look, or if you're interested in reading afterwards. These were sort of the final draft of my research questions. The big one was kind of how HIV/AIDS could inform issues like cancer, and then looking at some of the big debates that came out of the HIV/AIDS discourse and how it related. And then finally, we're in a brand new era for global health and for development. The Sustainable Development Goals were just announced in New York at the UN this past fall, and so where does the experience of a cancer patient fit into that moving forward through 2030? So I, again, will go pretty quickly through this. I know it's an interdisciplinary room, so I wanted to give a little bit of the background context. Cancers are now the leading cause of death worldwide. A lot of that is still being driven by high-income countries like the United States, but there's research to suggest that low and middle-income countries are projected to be a really substantial part of the burden in the next 15, 20 years. Right now, even though the incidence numbers don't look like they do in the high-income world, a really big issue is it's very high cancer mortality in regions like sub-Saharan Africa due to late diagnosis, lack of access to treatment, weak health systems, and that has huge costs catastrophically for families and for patients, but also at sort of the national level in terms of economic productivity. You're seeing a lot of younger populations with cancer in those settings, and that has a huge impact. And kind of with that and weak health systems, cancer's tough. It requires a really whole of system approach, kind of across the different treatment modalities, early diagnosis, screening, palliative care. There's a lot of components that go into the cancer care continuum, and that's a big task for countries that don't have large health budgets. So the image didn't quite come across super clearly. I apologize for that. This is a visual of the most commonly diagnosed cancers in sub-Saharan African countries. On the right, you can see with women, it's a pretty even split between breast and cervical cancer. For men, it's cancers plural. There's a number of different kind of major cancers. The blue is prostate cancer. The greens in West Africa is stomach and esophageal cancer, or liver and stomach cancer, actually. You have a big belt of Kaposi sarcoma in HIV, in predominantly HIV-affected countries in southern Africa, and a number of other ones. And so you're not talking a single disease like you were with HIV. It's a number of different cancers, different prognoses, different kinds of treatment, many different cancers, diverse set of risk factors. There's the ones that we know well in the States with breast, prostate, lung cancer, and you're talking about risk factors that, again, we know well: tobacco use and alcohol, dietary patterns, genetic predisposition being a big one, especially in breast and prostate. But the profile for Africa also looks pretty different. You have a lot of cancers that are primarily infectious in origin. You've got things like human papillomavirus being a huge driver in a really high mortality for cervical cancer, hepatitis B and C, HIV infection and how it relates to Kaposi sarcoma, Epstein-Barr virus, H. pylori. There's a number of kind of infectious agents that's a huge portion of the cancer burden. And things that are related to poverty more generally. A big one, more so than tobacco in a lot of poorer countries, is indoor air pollution, which is women with poorly ventilated cooking stoves in huts and kind of being in that smoky environment. A lot of times their families aren't buying cigarettes, but there's a huge risk for lung cancer, for esophageal cancer, for some of the other. And that really is poverty more generally. This is another visualization of the infectious disease burden. In North America and Europe, you can see it's about 4 to 7% of cancers have to do with infectious origin. In Africa, you're looking at about a third of all cancers, and there's a lot you can do with that in terms of addressing the underlying causes in the region. And yet, the global response is falling way behind the burden. Only 5% of resources for cancer globally is going to low and middle income countries. Only 1.2% of international aid is going to non-communicable diseases, which includes cancer, heart disease, diabetes, epilepsy, mental health, injuries, the whole spectrum of diseases that aren't infectious. Only 1.2% of aid. And if you look at countries where we work, Rwanda, Kenya, that's almost a third of the disease burden. And with no funding, naturally, lack of access to care, to affordable medicines, not a lot of research, not a lot of data specifically for countries in Africa. And without data, it's hard to make the argument. It's hard to make the argument for more programs and funding when you're talking to ministries of finance and the people who make those decisions. So what can we learn from HIV/AIDS? I'm not sure how familiar people are with HIV. I assume it's been kind of the marquee disease in the global health space, and something that's been a general public issue for a long time. It's an infectious disease with a really devastating burden. It came around in the 80s, and we had treatment in the mid-90s. The resident HIV expert can kind of talk a little bit more about HIV. But through a number of different things, through really intense advocacy from kind of NGOs and patient advocates, social justice movements, from kind of programs that went into countries where there was high levels of HIV and did programs, looked at prevention, tried to do community awareness. We started to counter the myth that complex long-term care is possible, even in the poorest countries, for a disease that is as devastating as HIV is. A lot of that for HIV had came from access to medicines. As soon as antiretrovirals came onto the scene, it was really expensive. It was, in 2000, it was about $10,000 for a year's worth of the drug regimen, and that was just not possible to do at a large scale. And so through a number of different pharmaceutical policies and through funding mechanisms, that became a reality to be able to get drugs to people who needed them in low-income countries. And then some really simple but very compelling and very rallying advocacy around the Millennium Development Goals, and discourses that were focused on human rights, marginalized communities, economic sustainability, making the argument for what the cost of inaction would be if we didn't do something about it, making the argument for countries like the US that diseases cross borders, and it's a national security issue if we don't address this, even if it's not happening in the same way in our populations. So this was the Millennium Development Goals, which came out in the early 2000s, that set the tone for our priorities for 2000 to 2015. One of the stories that I tell in the paper that I love is MDG 6, which is the HIV MDG, and has resulted in quite a bit of, very impactful in terms of that being a key part of funding priorities for the US government and a number of different big agencies. It was Kofi Annan who wrote, he was Secretary General at the UN, and he wrote that in without asking anyone about it. There had been stakeholder discussions on stakeholder discussions, and he saw it as a priority. He was looking at Africa. He wrote it in and asked for forgiveness later. And when it went back to the kind of quorum, they added in malaria and TB, but it stayed in. And so one person sort of set the tone for what's been incredibly impactful moving forward. This one is some of the iconic images from some of the activism. Also some of the funding agencies. PEPFAR, the President's Emergency Plan for AIDS Relief, was something that came under the Bush administration, George W. And in the early 2000s, it's been the largest single disease funder for any of the high-income country development agencies that's ever happened. Millions and millions of dollars that went into providing generic drugs to populations that needed it. The Global Fund is a centralized funding mechanism that a number of different countries and donors funnel resources in, focused again on the priority diseases, AIDS, TB, and malaria. And then the drug access piece. I don't need to take up much time right now on some of the pharmaceutical policy stuff, but if there's questions about that afterwards, we can definitely discuss. But through a number of different measures, through pushing generics, through patents and some other things, the cost of both first-line and generic prices has dropped really dramatically in the last 10, 15 years, and that's allowed, along with funding mechanisms from things like PEPFAR and the Global Fund, it's allowed scale up of treatment in a really exciting way. So some of the big debates, one of the big ones was kind of priority setting around prevention and treatment. If you look at the literature on HIV, there's a whole kind of era of really intense discussion around whether or not we should focus on prevention or treatment, and what puts us in a better place moving forward. For prevention proponents, a lot of it is kind of poor countries just simply lack the resources to treat their way out of the epidemic. It's too hard, it's too challenging, and it doesn't address the underlying causes. You're never gonna halt an epidemic by simply treating. You need to kind of get into the risk factors, and then it'll reduce the need for treatment moving forward. At the same token, treatment folks have another pretty good argument around prevention's also really hard. With HIV, you were looking at behavioral risk factors. It was sexual transmission is one of the main routes to transmission, and that's hard to change. It's cultural. There's a lot of gender politics. There's a lot of kind of ways that poverty has an impact in the countries we're talking about. And so by prevention-only approaches, you're condemning generations of patients, either who have the disease or, despite your best efforts, might still get the disease in years to come. Ultimately, out of all of that debate, it's a false dichotomy. HIV/AIDS demonstrated it needs to be both, and by having kind of a more complementary approach with both of those elements is really the way to go. Interestingly enough, if you look at the NCD movement and cancer and how it fits in, we are back to kind of a little bit where we started with HIV. It's a highly prevention focus, which when you have no funding, prevention is incredibly effective. It's one of the best ways to reduce the burden, especially low-hanging fruit. You can look at tobacco control, HPV vaccinations could reduce cervical cancer rates. Again, a little bit interesting to see sort of at World Health Organization, the way that they've rallied the NCDs at large. Definitely very prevention focused. The whole stretch in green is prevention. It's focused primarily on lifestyle risk factors, which is a factor for some of the diseases: alcohol, tobacco, physical activity, diet. Those sorts of things are definitely at play for some of the big cancers like breast cancer, but really doesn't kind of set priorities around infectious diseases, some of the poverty-related factors. And so there's missing things in there, and there's a lot more you can do, and there's definitely still a sense that cancer care, the treatment side of things, is too hard, it's too complicated, it's too expensive. And so there's a gap there. There's kind of severe inequities in access to cancer treatment. If you look at mortality to incidence ratios, it can be up to 20% higher in low and middle income countries. This is a graph for how many pathologists per millions of people in Africa by different countries. Some places it's more like 1 to 2.5 million people. There's a single pathologist. In some places it's many, many more than that. I think this graph looks pretty similar with oncologists. Franklin could let me know if not. If you look at things like radiation, because again, you're looking at multiple modalities, it's not a single drug regimen, only 18% of the population globally has access to radiation. Where we work in Rwanda, one of the kind of stories, we had one of our cancer docs do a presentation a few months ago, and he was talking about how they don't have radiation services in Rwanda. We have a really wonderful clinic, expert center for cancer care that serves a huge portion of the region in both Rwanda and some of the surrounding countries. But Rwanda doesn't have radiation. Uganda does, and so they get a quota of the number of people that they can send to Uganda for radiation over the course of the year. It's absurdly low. It's 15 or 30 people over an entire year. So as clinicians who are trying to do the best for their patients, they have to make that really, really awful choice around who can go to Uganda to get radiation and who has kind of the best prognosis to kind of extend their life. And no clinician should ever have to make that choice. And they're lucky because they have somewhere to send patients if they want to. And so that there's a huge gap in terms of treatment. When you look at approaches to kind of care, and one of the things that the HIV/AIDS movement did is contribute pretty significantly to siloing health agendas into disease-specific programs. It was really effective. A lot of funding funneled straight into HIV programs to do different things, whether that was prevention, community awareness, clinical programs. There was palliative care programs specifically for HIV, training HIV nurses, and a lot. They did a really great job. There's a lot of kind of things left to do in HIV, but it was effective. It helped curb the spread of the epidemic. It was really kind of focusing on HIV and having a single issue that was easy to rally around was instrumental in raising awareness and funding. On the flip side of that, you have kind of, rather than vertical disease-specific programs, a lot of people would kind of propose that it is more of a kind of broader health system strengthening is the buzzword we use a lot. Kind of looking more comprehensively across diseases, across platforms, looking at things like human resources for health across, not necessarily just having an HIV nurse, but having nurses that can provide care across diseases. That is a little bit harder to define, a little bit harder to figure out sort of where our priorities are moving forward. And isn't the disease-specific stuff is so effective on the advocacy funding realm. And so a question of, do you need a mix of both? Kind of understand the broader, but be able to use targeted approaches in a way that works. For cancer, I think that sort of integrated approach is a lot about building on what's come before. Some of the easiest win-wins are looking at how cancer can be integrated into existing platforms with things like vaccination coverage for cervical and liver cancer, having cervical cancer services wrapped up into maternal and child health programs targeted at girls and young mothers, looking at early detection and screening programs across diseases. There's a really great platform built from HIV. What happens if you throw in sort of detection services for diabetes and cancer all together? Is that something that makes sense? On HIV, there's a lot there to build on, whether it's sort of referral and follow-up services for HIV patients who may get some of the HIV-associated cancers, or looking at some of the programs that they've done really well with palliative care and pain relief and ways to use that in other diseases. Looking at human resources for health and training protocols, either expanding on what countries are currently using or using really effective models to design what training and protocols look like for cancer. And then when you're talking about multiple modalities, things like surgery is a really great cross-cutting. There's a lot of surgical training needed for priority cancers. And so thinking strategically about ways to kind of leverage what's happening in global surgery and make sure it works for the need for cancer. And then the question to kind of ask yourself at the end of the day is, how do we ensure that cancer doesn't get lost in the shuffle? Sometimes there are things that are cancer specific. Radiation isn't going to get kind of cobbled together from other health agendas or other platforms. It's something that really it's for cancer and it needs to be a priority. And so kind of what can the cancer community do to raise awareness around that and to try to get those services in places where you need it? And so the last piece, and I can go pretty briefly through this one, is access to medicines. It was something that HIV did really effectively. And there's been encouraging progress in cancer. If you look at the essential medicines list, which was just reviewed at the WHO level, most of the drugs are already off patent. There was a big victory that India won against Novartis, a drug company, around a generic patent bid for a leukemia drug. And that's a huge deal because India is 80% of the generics market and really instrumental in getting drugs to lower income countries. But there's a lot of barriers that still exist. We can dig into this a little bit if people are interested, but there's a lot of countries that struggle to take advantage of facilitative processes, policies around pharmaceutical access, and a lot of big players that are less friendly to kind of lower income countries. I said it before, but we're not talking a single drug regimen. There's a lot of different modalities. You are looking at chemo, you're looking at certain sort of adjuvant drugs, and then surgery is a big one, radiation, all sorts of different things at play. And regardless of what particularly you're looking at in terms of access to treatment, you need funding. And so a question really becomes, how do we rally the global community around this issue? And what are the implications for the longer range future? With the Sustainable Development Goals agenda recently being announced, we're at a pretty cool moment, a very historic crossroads for NCDs and cancer. We're on the agenda for the first time in possibly ever at the UN level. And so what does that mean? How do we think through what are the longer term solutions? There's a lot of kind of easy wins right now, but in terms of sort of long-term care and building health systems, what does that look like for cancer? And then I included this. It's from our work in PIH. It was a blog post that was put on our website in 2012. I really love the story here. I love kind of the learning about what we're doing and hearing from our clinicians. And it's a big reason why when I posed the last question in my paper, I didn't have it, where does cancer fit into the SGDs, but where does a cancer patient fit in? Because at the end of the day, that's what we're looking at, and that's kind of why it matters and why the big macro funding policy, what it filters down to and who it affects. So my last slide is just some quotes that I included because of how eerily they relate to each other. The first one was Peter Piot in 2002 or 2003, who was executive director at UNAIDS at the time. The second was a couple of years ago with the president of Nigeria. And so there's a lot of interesting parallels between the two. There's ways that cancer and NCDs, or cancer and HIV obviously differ, but there's a lot of lessons to learn. And so kind of looking at how cancer can do things even more strategically, and what are the gaps and what are the opportunities. So, thank you.
Thank you very much.
Well, thanks, and it's a great pleasure to be here at the Pardee Center, part because I like to think that the work we do is also very interdisciplinary, and so I think there'll be lessons to be learned in talking to hopefully many other people here. So my name is Franklin Huang. I'm an oncologist at Dana-Farber down the street. I'm also the co-founder with Ami Bhatt, who's the director of global oncology at Stanford University and a professor there of global oncology, which is a nonprofit we founded several years ago now. And it's a great pleasure to be here. It's even a greater pleasure to be here on a panel with Maia, who I'm very proud of for both her work that she's done here at BU, in addition to her work that she's done with us at GO. So what I thought I'd do is describe a little bit about the work we do, why we do it, and why it's important, and how we're approaching this, but both from an innovation standpoint and from setting the stage for the problems of how we might tackle this as a global community. So I'm going to pose a statement that I don't think is that provocative, but maybe it is, and that I really do think that cancer is the global health challenge for this generation and the generations to come. In part, if you think about, Maia has mentioned that PEPFAR has been an enormous heroic effort and success by many measures from our country, and about $70 billion has been spent over the last 15 or 20 years or so on that effort. And while we've put many people on treatment, there are still many people who now are living beyond their expected age previously, but are now coming down with breast cancer, with cervical cancer, with many other cancers that actually do affect patients with HIV. So the challenge is huge, and there are many different problems within this, but I thought I'd offer some of the solutions that we've tried to attempt within our organization and as a community, and there are many organizations that are now tilting towards cancer and other NCDs and thinking about ways in which to approach this problem. So why global oncology? So what I've posed up here is that we estimate that about 1 billion people will die over the next century from cancer, and most will be in low and middle income countries if the trends continue, and that many will not have access to high quality cancer care, as you and I might know it, or palliative care. And this is an enormous burden and an enormous amount of suffering that will occur over the next century. When we think of cancer care and the cancer care spectrum, we think of surgery, radiotherapy, pathology, palliative care, and these services are severely lacking in many of these settings. And just to highlight one example where there's been enormous success in cancer care in the US and other developed countries is for pediatric cancers, where the survival rate and the cure rate is quite high, above 80% for most kids who are diagnosed with cancer. But the majority of the burden is actually not in the developed world, it's actually in the developing world, and most of those children will die from a curable cancer. So it really goes to show you that where you live will determine your survival from cancer. And so just to describe our work, and is a nonprofit organization dedicated to bringing the best in cancer care to underserved patients around the world. It was founded in 2012, as I said, by 2 medical oncology fellows at Harvard. And our goals are really to improve diagnosis, treatment, and care in underserved cancer patients, and build networks, it's missing here, that engage and work together to improve global cancer care. And our model really is to take folks from the community, skilled professionals, and build volunteer core teams, and then work with partners and collaborators on needs and challenges on the ground. And so our idea, or our concept is that our volunteers, that everyone can have an impact. And these are multidisciplinary teams of volunteers that include computer scientists, designers, health professionals and trainees, clinicians, students, social workers. And this is how we started out in this process, really just asking the question, what are the problems on the ground with our collaborators and partners, and how might we address them through projects that we could develop here? And so I'll highlight a few problems that we addressed, that we came across and encountered in our conversations and our personal networks with various cancer care providers in low and middle income countries. One question that was addressed, and this is a project that Maia led for GO, was that cancer patients in low income countries often lack knowledge of their diagnosis and treatment and have low literacy rates. So many patients will show up to the clinic, be told they have a cancer diagnosis, and then be told to show up at a specific time to start treatment. The reams of paper and internet access that we're used to here to understand and understand the diagnosis and what lays ahead is not present. So we embarked on a project with a local design firm called The Meme, who donated their services to us. Maia did a tremendous amount of research and literature and talking to health communications experts. We engaged with care providers in Rwanda, in Malawi, and in Haiti to build these first of its kind cancer educational materials designed specifically for low literacy patients. And as you can see, these are pictorial books that really describe what the process might be, potential side effects, when to report to the clinician or the hospital based on side effects. And these are some of the GO volunteers who've helped out on developing these materials. These were piloted again, as I said, in Malawi and in Butaro and Rwanda, really to understand how well were these materials understood and help co-create these with the patient population in mind. Another problem, and that now is being implemented actually in Haiti right now, that was implemented over the summer by a Harvard medical student named Lori Schleimer. Now, another problem that we encountered in discussions with a number of stakeholders was, how do we align global cancer control efforts? One of the questions that has long been asked is, who's doing what and where? And our question was, could we catalog and map every cancer research and control project that was occurring? So we developed what is now called the GCPM and what's called the Global Cancer Project Map. And the goal of which was to facilitate the building of collaborations across organizations, to accelerate progress, ensure balanced investment of resources, and align these efforts, and then provide resources to view and better understand international efforts in cancer research and control. And this was launched this past year at the CUGH meeting that was held in Boston in March of 2015, and it's a collaboration and funded by the NCI Center for Global Health and Latos Biomed. And what we did was we took data that had been from the portfolio of NIH-funded projects that had collaborations outside of the United States, as well as partner data from Aortic, ASCO, and UICC, other major organizations working in cancer, and started to map these projects on this global map, as you can see. And you can go to this website and you can search through the different projects, so that now if you're a student or you're a researcher or you're someone who wants to work in cancer in these various countries, you can go to that country and see who's doing what and where and what kind of work are they doing. Again, the data is continuing to come in, but we hope to plan to later this year launch a newer version of the map. And this also shows that you can start to look at disparities between what projects are going on where, based on, we have layers that one can overlay on top of the map to show burden of disease. This is data provided by ARC and GlobalCan, the global burden of disease in terms of DALYs from IHME, and the Human Development Index. So another problem that we've encountered is that, as Maia mentioned, there are very few oncologists for large populations. One of our partners in Malawi, he's one oncologist, Dr. Leo Masamba in Blantyre, Malawi, for a population of millions in Malawi. And so we understood that cancer care expertise is not available in many resource-constrained settings. And as oncologists, we often field questions about various cases of friends, colleagues, family members. And so what we've decided to do is how could we address this issue of cancer care expertise not being available in many of these settings? And we had two different solutions. One was a case conference, a tumor board, as we like to call them sometimes, with our partners in Malawi, and this would be held monthly, and it's based out of Dana-Farber or MGH. And where we would invite a cancer care expert, provide a consultation and advising on a case that was going on or previously in Malawi, and then also do teaching associated with that case to provide education to both nurses and clinicians on the ground in Malawi. We also embarked on a collaboration with a company called Best Doctors, and this is called GoCap. And this provides an online platform that allows for treating providers to upload cases about cancer patients onto this site. We would then contact within our network of oncologists an expert in that specific cancer who would then respond to that specific case and provide advising information. And this just gives you some of the goals of that platform to enable treating providers to obtain an expert consultation, to generate community and dialogue, and then to disseminate the expert care we provide in Boston and in other places globally in an easily accessible manner. And this just gives you some representative images of the type of media that one can upload. It's as easy as uploading media to Facebook or what have you. And then here are examples of some of the commentaries that have come through on various cases. I believe this one is specifically from Nepal, but that we've been able to pilot this in a number of different settings. There have been 12 cases uploaded. This is a little bit outdated, but 12 cases uploaded from various sites. There are about 40 registered users, and our next steps are really to build an active network of treating providers and volunteer consultants. As you know, there's a tremendous number of knowledge within many academic medical centers, and we really want to harness that knowledge to help provide care in settings where you will not achieve enough number of oncologists, expert oncologists, for the patient population and demand that exists. So just to quickly finish here, these are a number of our collaborators and network who work with us and who we work with to try and address the problem of global cancer control. And again, as I said, I think that it is a critical mission that we're trying to undertake, and that Maia so nicely describes in both her work here and in the talk today. I'd just like to briefly say how you might get involved. There is a Go Young Professional Alliance that is also based here at BU. You could attend or volunteer with some of our projects, including the tumor boards or the help us expand our cancer educational materials to patients and providers. And then also as a plug for our upcoming NCI's Global Cancer Research Symposium to be held at San Francisco on April 8th, and that's co-sponsored by the NCI, CGH, UCSF, Stanford, and Go. So with that, I'd say thank you, and I guess we'll take questions going forward.
Okay. Thank you very much. So I'm going to take probably just about 5 minutes to take a slightly, they have focused on specifically cancer and focusing on sub-Saharan Africa. I'm going to step back a little bit to talk briefly about non-communicable diseases more generally in the low and middle income countries. So this is I think we're still in the time period when it's just dawning on the global health community that NCDs are not just a problem of rich countries. The data have only started to come in the last, say, 15, 20 years, and it takes a while for the community to kind of catch up. So you can see that in 2002, in low and middle income countries, the NCDs, which are the blue, the sort of the grayish blue, were 44% of the total, and now it's 54% projected for 2030. So this is kind of a new phenomenon that we're just taking into account. This shows how quickly it's happened in the Philippines, where the blue line, the declining line, is communicable diseases, and then the sort of greeny line there, it's a different color on my screen here. The orangey line is heart diseases, and the reddish line is cancers. And it was as recent as 1986 that there were more cancer deaths than infectious disease deaths. So in a way, it's not surprising that we're trying to catch up to this new phenomenon. This is a slide, actually Maia did a good job of kind of covering the issues around funding. This shows the communicable disease, the NCD money that's been available since 1990, when the first burden of disease estimates were published that showed this huge burden of non-communicable diseases in low and middle income countries. And it's interesting to see that the majority of the new money, the green bars on the end there, is from foundations, specifically Bloomberg Foundation and the Bill and Melinda Gates Foundation. So we still haven't really engaged the energies and the funding of the major bilateral organizations like USAID, which are the trundling along there at the very bottom of the slide in the red. We haven't really gotten the World Bank to engage. There was some, the sort of yellow bars are World Bank money, but then there was some effort, and then it's actually declined over time. They seem to be moving on to other things. So there's still a lot of work needing to be done in engaging and solidifying the funding base. This is actually, well, you can't really see it very easily. This is the flow of funds from 1990 to 2014, and here is where the non-communicable disease block is. And you can see it's a very, very small, tiny, tiny, tiny little amount of money compared to HIV and some of the other newborn and maternal and child health and so on. So again, the same idea. We're really having very little funding. The per DALI funding is very small too. The red circle shows down here it's less than, it's about $3 or $4 per DALI as compared to something more on the order of $35 or $40 for maternal and child health per DALI lost. So again, there's a huge misalignment of the DALI burden and the amount of money we're spending to address it. This is a calculation made by Rachel Nugent and Andrea Fagel in an article, a paper they put out on funding for NCDs, where they calculated that HIV, TB, and malaria, just those three, get about $24 per DALI, and NCDs got around 58 cents. So again, same kind of picture. Where does the money for NCDs go? Well, it's interesting to see that there is a big bar for general sort of health services strengthening. The vast majority of the specified funds is going for tobacco. And you might well say, as well it should be. Tobacco is a major, major cause of cancers and all kinds of heart disease, all kinds of other NCDs. But we can see that very little is being spent on cancer down here in the second bar from the left. And so we really need to do better on this. What are the prospects for doing better? Countries are already doing what they can with what they've got, and I think there should well be some questions about how well they're doing it, how effectively and how equitably. I think there are definitely some equity issues that if you can get access to there are some cancer centers of excellence. For example, there's one in Uganda, as was mentioned. Who is actually getting access to that care? I think we have to look carefully at, who's getting that. Who is getting sent to another country, to Kenya or to South Africa for care of their cancer? Again, most likely to be higher income individuals. Most of the burden is falling not on government health services, but on individuals and their families, and they're paying out of pocket. So this is a huge, financially devastating, in addition to all the other emotional and other devastations that NCD, particularly cancer, could bring. It is really bankrupting families and compromises the prospects for the children of that family going forward. The symbolism of NCDs, which affect mostly adults, although in the low and middle income countries it affects adults at a younger age than in the Western world. But there's the fact that it's often linked to lifestyle issues. There's the willpower, lacking of willpower paradigm and so on. Those all suggest that it's going to be difficult. This is not going to be an easy walk to actually make a change. There are very strong arguments, though, on the basis of economic grounds, and the World Bank was actually in the forefront of kind of doing some of this work a few years ago, showing that, the health of the workforce is very important to the economy of a country. So a sick workforce that has a lot of days off due to cancers or due to heart disease or stroke or whatever is not going to advance as quickly economically. There's also the market element that, businesses want a healthy market that can buy their products. So you can incorporate the self-interest of businesses and industry in terms of investing in the well-being of their potential market. Because if you have a choice, you're sick with heart disease or cancer, you can either spend money on that or you can spend it on a new refrigerator. So the refrigerator industry should be worried about the fact that so much of people's energy and money is going to care for these diseases. And this is a point I think we need to keep in mind. Unlike the infectious diseases and maternal and child health, which have no industries that are against them, you cannot be against improving maternal and child health. You cannot be against reducing infectious diseases. However, when you start to talk about lifestyles and risk factors for NCDs, there are some very, very powerful industries that like things just the way they are. Thank you very much. The alcohol industry, the tobacco industry, they would like to see no change. They would like to actually roll back time to much less regulated time and place. There's also the food manufacturers who have a large interest in the creation of these odd foods that we eat now, foods that your grandmother would not have recognized. Extruded potato products with, what did I have the other day? It was really awful. Oh, sriracha potato chips. They weren't really potato chips, and I don't know if it was really sriracha, but I thought, who thought of this? It was really, and I had a bacon potato chip, too, the other day. At Whole Foods. Whole Foods is selling bacon potato chips. What can I tell you? This was an example, too. A country, Samoa, that was trying hard to reduce the heavy burden of diabetes and obesity that they face, was trying to reduce the importation of turkey tails, which is that piece of fat at the back end of the turkey, which is, they are exported in large quantities to the Western Pacific and the islands. And the Samoans deep fry them and consider it a delicacy, but it's about the most unhealthy thing you could possibly eat. So they wanted to reduce the importation. And the U.S. Trade Representative came down heavy on them. And so in exchange for reducing this ban, they got access to the World Trade Organization, which is something they'd wanted for a long, long time. So trade trumped, pardon the word, choice of word, trade trumped health in this particular setting. So what can be done? I think, as both our previous speakers mentioned, we need to better align the burden of disease with the expenditures. We have good evidence. It's not the greatest evidence, but it's strong and it's getting pretty convincing. We need to look for ways to improve the symbolism and change the balance in favor of the NCDs. I really liked Maia's last slide with that person with cancer, that individual woman. Not just a number, one of millions, one of thousands, but a real person who was a success story and was cured of this disease through this intervention. We can use the framing of the issue more along the lines of not this fat man who ate too much and got heart disease, but this breadwinner who had a stroke and now his children are destitute. This woman who died of cervical cancer, a mother died of cervical cancer, and now she's left 5 orphans. To put it in that kind of broader context, I think can help with that symbolism issue. The existing efficiency and effectiveness and equity and equality, as I mentioned, of the existing care and prevention, I think countries need a lot of help. There's still, if you go to a Ministry of Health, if there is an NCD department, which is already not always a guarantee, it's so understaffed, it may have 1 or 2 people who have really a very strong, a very big task ahead of them. And so they need to be able to realize they need some help and to know what kind of help they can access. And then finally, prevention. There's so much that we can do to rein in the business interests that are, in many cases, mitigating or militating against prevention methods that we'd like to incorporate, and take advantage of the opportunities to address the infectious causes of NCDs, particularly cancers that were mentioned by the previous speaker. So thank you for your attention, and I guess you have some questions. There's a question. Professor Zaman, if I'm not mistaken.
Thank you so much. So as somebody who works in cancer, one of the things that jumped at me, and perhaps is the elephant in the room here, is the lack of emphasis on basic science, right? So, I mean, we are making sort of these important discoveries that may have relevance for Africa in a completely different sense because, let's say, their dietary sort of approach is different, or their immune response is different, or there is pressure on their DNA because there's a lot of marriages in their own tribes, or issues that we see, for example, of chemoresistance that we haven't fully explored in those communities. Now, where is that going to come from? And I think, is there in your own work an appreciation that cancer challenges in sub-Saharan Africa may also require new discoveries and new efforts in basic science, in addition to sort of providing them with the cure that we think is relevant for a very different genetic racial population?
Yeah, I mean, I'll let the researcher field some of this as far as the basic science piece goes. But absolutely, I mean, I think the gap in research is huge. We do a lot of work kind of tied to Harvard on NCDs and cancer, and we don't know if we know the burden right now. We certainly, there's data that's out there. We know kind of anecdotally, we see patients all the time. The cancer clinic, the cancer center that we run in Rwanda is bursting to the seams with patients, not enough people to treat them. But there are really specific regional stuff going on, whether that's sort of at the basic science level or if it's about kind of how to do effective care in different settings on the basic science.
Yeah, no, I think it's a phenomenal question. I mean, I think it's interesting. I mean, in my day job or the work that I'm doing, I'm working on cancer genomics and understanding what are the alterations that may be specific to certain populations, and how does that manifest it in both cancer susceptibility, response to treatment, and whatnot. So you bring a great point, and I think that it's a huge data black hole in terms of what's going on in various different populations. Are we merely extrapolating data from clinical trials and studies that have been produced in largely Western populations? Although there are studies in Asia and in other parts of Central and South America, and then just merely extrapolating and saying we need to provide these exact same medicines in these patients. So I agree with you. I think that we need much more data on the outcomes, how patients respond, and I think that is a basic science question. I think that is the argument that needs to be made to the federal government, to various foundations, about why it's important to study in other populations the drugs that we think are, advancing precision medicine. How will those really be applied to other populations that have yet to see these types of drugs? There may be no reason to expect that to, but I think we need the data to really say that.
Yes.
So I wonder if you would
Wait, there's a microphone coming.
I wonder if you would comment on the exposure to toxics and pollution. We know that there's a heavy burden of lead poisoning, for example, in many of these countries. Should I say that again? Sure. I wonder if you would comment on the exposure to toxics and pollution, lead poisoning as one example, but many other threats that people in these countries face, and what you can do about it, and what you expect the burden is, the relative burden.
Yeah, absolutely. And it was sort of on the list of things that I was going to mention on that slide around risk factors. Definitely, especially, I mean, we know it in the US, but it's with breast cancer and some of the things there's a lot of environmental contaminants, liver cancer with aflatoxin contamination, which is a big kind of part of the agricultural production, especially in West Africa. There's definitely a lot of things at play there. It's something that is rarely talked about, even in the U.S. It's kind of with breast cancer. There's so much around kind of lifestyle risk factors and what you can do as patients to prevent it, and kind of onus on the population themselves. But there's definitely kind of the environmental contamination piece. I don't know if there's data around toxicity specifically in kind of sub-Saharan Africa or in low-income countries. China's a big one where those numbers are starting to come around some of their industrial production.
You mentioned in your talk one of the largest sources, and that's the indoor air pollution from cooking
absolutely.
stoves, from solid fuels. That's a worldwide problem. Wherever people are cooking with wood, dung, agricultural residues, and so on, the smoke is one of the problems. It's not just it causes all kinds of problems. But there is a lot of work being done to disseminate improved stoves and improved ways, because one of the other problems that comes with that kind of fuel is deforestation and poverty due to the amount of people's income they have to spend on fuel, or the amount of time they have to spend on finding fuel. So more improved cook stoves and different kind of mechanisms to use existing fuels more carefully there's a lot of effort going on that. And I think there's very promising things there.
Yeah, there's a really great organization called the Global Alliance for Cook Stoves that is doing some of the stuff especially focused on countries with high burdens of poverty. And then if you look at kind of countries, there's a lot of really interesting sort of smaller endeavors. There's folks that we know in Rwanda that are doing things out of pellets and different production to try to lessen that burden. So encouraging progress, but it's that sort of macro level issue that's really, really tough to get a response around that. And I don't know that we know the extent of the burden.
Yeah.
So I had a question about social, some of you talked about the disparities in access. So I had a question about rural-urban disparities, because as you know, some of the issues that you're talking about seem more pertinent to urban areas. And I do want to know about cancers in rural areas, because a large population, both in South Asia, Southeast Asia, as well as Africa, is rural. And the other question I had with regard to some of the things that you mentioned is telemedicine. You are talking about education doctor to doctor, and you talked about education to actual patient. So how does this kind of, telemedicine and approach via other channels help in cancer education?
Sure. So on the rural poverty piece, that's primarily kind of the areas that we work with at Partners in Health. And so some of the sort of poverty-related risk factors and some of the kind of work that we do is specifically focused on that. I think when you're getting to sort of the care level, because there's such a dearth of specialists, you'll have, if anything, a single center that has a little bit more oncology capacity. It's usually not oncologists, but it's nurses and clinicians who are providing cancer-specific care. That if a country has kind of a country like Rwanda or Haiti, or it's usually one, and then there's that sort of access issue for rural patients to be able to get there. And so then it kind of becomes a question of how can you capacitate community health workers to be able to sort of recognize and refer and get support to patients who are sort of at the last mile. Urban poverty and urban settings, especially with some of the rising middle income countries and sort of the low income countries on sort of the upswing, is definitely an issue. It connects with the pollution piece. It connects with a number of the different risk factors with lifestyle stuff. And I don't know that kind of in countries like Rwanda or Malawi, the care is, there's kind of more private care in places like Nairobi. But if you're poor, whether you're urban or rural, accessing that as the same set of barriers. On the telemedicine, or if other people have thoughts?
I mean, I would say for telemedicine, I think there are certainly plenty of opportunities to really think about technologies and access to care that goes beyond what's currently available. I mean, really, there's, like I said, I think that the amount of staff needed to staff a hospital and it's just, we're way off from that at this point. So thinking about ways in which physicians, nurses, social workers, chemotherapy, pharmacists can access the expertise and the knowledge they need, I think is really important. And I think part of that solution is potentially telemedicine or some type of access to resources that can guide them on providing that care. With our partners at Butaro and Partners in Health, for a long time, they've been accessing experts at Dana-Farber to help guide them on care of pediatric and adult oncology patients. So clearly, there are many different models that could potentially work about how to as Maia mentioned, capacitate knowledge and expertise on various treatments of these very specialized cancers. Because as you said, there are over 200 cancers. So having the knowledge to treat every single one, we really need the global community and there are many experts out there who can help advise on these types of cases.
Yeah.
Hi, I'm just returning to this idea of literacy, of health literacy. Is there any data to show that if the access to care was stronger, if care was more accessible, that people would in fact access it?
It's a complicated question. I don't know data offhand, but
there is a strong feedback loop.
Absolutely.
There's the 3 delays model. I don't know if you've ever encountered that, which is actually, it comes out of the maternal and child health world. They looked at the delays that women encounter in getting to obstetric care in case of an emergency, something's going wrong. And the first delay was recognizing there was a problem and deciding to take steps. The second was to actually access that care, and is the bridge open? Is there a car, and so on. But the third was the quality of care at the facility. And it turned out that when they looked at the model a little bit more carefully, that there was a feedback loop, that if people knew that the quality of care was going to be poor, or there wasn't likely to be anybody there, or the person that was there was going to be rude or whatever, or it was going to be too expensive, then they wouldn't, that influenced their decision to whether or not whether it was even worth trying to get to this care. So I think there's plenty of, I don't know about data. Data in the low and middle income countries is always so scarce, and a lot of it is kind of suspect anyway, what we call data. There's plenty of anecdotes.
Right, and in terms of the work that we're doing with Go, and it's a project that I've kind of had the honor to, I helped start and been a part of since day one, the sort of barrier that we were seeing, and it was brought to us by Malawi. It was the hospital, Queen Elizabeth, that we work with in Malawi. And what they were seeing is that patients who made it to the cancer center to get care, started on treatment, and didn't understand sort of why chemo was making them more sick. And there was this sort of loss to follow-up, which the caregivers didn't kind of have the data to necessarily say that it was because of lack of literacy, but they were incredibly overworked. They didn't have the time to sit down with patients and have those conversations, sit with the families. And so when they brought it to us, it was through some of the tumor boards with social workers. We did a similar process with some of the nurses and caregivers that aren't kind of on the technical oncology piece. And they asked me to go find if there were versions that existed for other African countries. And so I sort of naively went off to go find that perfect thing, and it didn't exist. There wasn't anything that had ever been done looking at the kind of populations that we were working with in Malawi. And so we then went through the process of creating that with them in mind, and used kind of And we're starting to, we're a couple of years into the project. We have, we're now at version, 3 or 4 at this point, after lots of qualitative kind of conversations back and forth. And we're starting to get some data around effectiveness, which is really exciting to kind of really see if there are links that we can prove on the student that was in Haiti looked specifically at kind of what people knew before they came into encounter with the booklets, and whether or not those changed afterwards and changed their perceptions on what's possible and what care they could get. It's a hard link to then make to the broader kind of will that change outcomes, but there's exciting stuff happening.
Yeah, you hear, in terms of the anecdote, and I'll suffer from the same thing, and you hear anecdotes of, referral patterns where a patient with breast cancer gets referred to, from a village 3 hours away, gets referred to the cancer center, does well, goes back, and then you see this influx of referrals from that same village, in part because, I think there is no better demonstration of the effectiveness and what we do in cancer medicine than a patient who does well. And so I think that, while we need much more epidemiology and studies in the field that demonstrate that, I think that those are very powerful stories that we talk about and that do exist.
Yeah, one of my favorites, a buddy of mine, Fidel, who's one of our general physicians who does cancer services at Butaro. He was in Boston for ACS, did a advocacy seminar and workshop, and he was one of the global scholars chosen. So he was here, and we were just chatting about stuff. And the story of his that I absolutely love is right before he came to Boston for this thing, he had a patient, a woman in her 30s, who showed up with a mass. It was pretty early. It wasn't kind of late diagnosis. And she said she came because there was a radio address from the Rwandan government talking about the services in Butaro. And she hadn't heard of it. She hadn't had anyone in her kind of community with cancer who had been to Butaro, and that was what signaled for her to go. And Fidel was just so thrilled because that was something that they were starting to do more of, as community education and awareness, and it was making a difference. And she was fine because it was early diagnosis. It wasn't the huge mass that's really hard to deal with. And so there's always good stories. We need the data and the research, and
You need the money to do the data.
the money to do
collect
the
the data
programs
and do the research. Yeah.
and it's awful cycle
Yeah.
that we're in right now.
So a lot of the factors you cited had to do with diet for cancers. And when we look at the MGDs or most development efforts, there's kind of a tension here then between dealing with these cancer concerns as well as food security and poverty alleviation. And we can see specifically thinking about dietary transitions and the nutrition transition that's taking place in the development world, perhaps coming to a head here as people increase their affluence and change the production systems in their countries, thereby changing their diets and risk for cancer. So, but the funders who are addressing food security and that you listed who are funding NCD work are often the same. So is there anyone who's actually taking on these agendas simultaneously or considering the linkages for how their food security activities and efforts to fight NCDs could be linked?
I'll make a quick point first and then think about the sort of bigger question that you asked. I think certainly the lifestyle risk factors that we kind of talk about with obesity and overeating and those sorts of things, poor diets, bad food, is very prevalent. When you look at NCDs kind of broadly, and I think there's questions about cancer, malnutrition also has an impact, and especially if you're looking at sort of exclusive breastfeeding and sort of reproductive stuff with breast cancer and in diabetes, we're doing a big project in diabetes, and there's a lot of people that are getting diabetes that are undernourished, and so it's not necessarily, it's a different burden. It's whether they're predictive factors or just it's not the simplest of stories. So malnutrition, I think, also has a plays into things. In terms of funders that are doing both, I think Gates is USAID is definitely huge maternal child
yeah.
health. I think Gates has had a bit of a. It's interesting to see them show up as high as they do on that graph, because they've had a bit of a firewall on NCDs, where Gates himself has said, I'm not interested. But in terms of sort of linking, it's the people that do really strong work in maternal and child health that are looking at, cervical cancer has been the big one of kind of ways to combine those agendas. On the food security piece, I don't know.
Yeah, and it's interesting because a lot of the bad food is not, I mean, more wealthy people are eating some of the bad food, but a lot of the bad food is also being consumed by poor people, as here in the States. I live in Jamaica Plain. I go into my local Stop and Shop, and there's the so-called value aisle, which is the stuff that's on sale and cheap, and it's Fruit Loops cereal, sugary drinks, chips, pretzels, nothing very good for you, but it's all really cheap calories. So if you go down that aisle, and it's the first one right next to the fruits and vegetables, right there, and, you can load up for $10, get a whole lot of calories in your basket. They're not very good calories, but I see a lot of people going down that way.
And the things that
in JP,
the things that get imported into countries is ramen packets
Yeah.
and Gatorade things, and it's...
and turkey tails.
Yeah, but then, to think about who's bridging those two issues, it's happening a bit in kind of people being interested in the research and advocacy.
And the other thing is the global junk food industry is another. I mean, you see KFC and McDonald's and all the equivalent local versions of it everywhere, and that's where a lot of people, particularly rural, urban people who are, don't have time to go home for lunch. Like in the old days, people would have gone home for lunch, and now that just doesn't happen. So they'll get a piece of fried chicken and some fries for lunch, and that's part of the global sort of junk food expansion that's happened. I was really struck. I was in Kingston, Jamaica, a few years ago, and the main street of Kingston was one junk food emporium after the other, and they were mostly local. They were not American brands. They were local Jamaican brands, and but there was one fried thing after the other. There was really nothing very healthy, and whatever the original Jamaican diet had been was pretty submerged under the junk food prevalence that I could see. And Jamaica has incredibly high rates of diabetes too, unfortunately.
I'm glad she actually mentioned, because we're so focused on kind of the countries that PIH works, which is very rural poverty, and it's a little bit of a different risk factor burden. But if you kind of when we go to the UN or to Geneva and do some of the sort of the bigger policy meetings, the Healthy Caribbean Coalition, some of the NCD advocates that are coming out of the Caribbean and also to some extent the Pacific Islands, they're doing some pretty awesome stuff in targeting kind of food and some of the food security lifestyle risk factor stuff. There's a really kind of great group of younger advocates who are getting involved. They, as a coalition of member states, have a pretty great track record in terms of getting some of the legislation through in their countries and some of the small island states. And so that they're always a really strong voice when we show up in New York or in Geneva. It's a little less relevant for kind of the set of things that we're looking at, but it's always really fun to hear from them. And so I don't know, there's probably some great organizations that's feeling that on the civil society end of things, but there's definitely a number of kind of public sector leaders from those organizations and NCDs that are doing some really cool work. It's a tough, they're fighting against a lot
big
in
industry,
those countries.
big industry. Do we have time for one more question? Couple? Okay, great. Any other questions? I'm sure there's one out there. Deanna, yes.
Okay. Oh, yes. You talked about how with your program that you were in with the fellowship, are there any opportunities for like undergrad, maybe seniors transitioning to graduate school to do like a research?
I might shoot that one back to Cynthia and Tony. I can tell you all about the graduate fellowship, and it was really valuable for me in a number of ways. But in terms of undergrad opportunities,
there is a whole program for undergraduate research opportunities, and that's I think a really important resource for the center. We're really focused on for the fellowships. We're really focused on people who are already enrolled as BU graduate students, but we often find faculty who are associated with the center who've got, they've got needs for undergraduate research assistants, and so it's certainly, sort of worth checking in, because, those opportunities crop up sort of irregularly, but they're not zero either.
Any other questions? Yeah, in the back.
Hi. So, hello. Is this working? Okay. So we talked about a little bit during the HIV/AIDS epidemic, this kind of concept of beating up a story. So how do we get these higher income countries to pay attention to this problem occurring in low middle income countries? Do you think for cancer and NCDs, we need to start maybe so-called beating up a story to get the attention of funders to get the necessary finance for research, and how would that look?
About 1,000% yes. No, it comes in different ways. If you're interested in that sort of question, there's a really cool report that came out of the Center for Foreign Relations, CFR, from Tom Balaki, and they did a similar thing, kind of looking broadly at low and middle income countries. So it's a little bit broader than the work that we do, kind of specifically on rural poverty with PIH. But as they started to kind of knock on the doors of senators and talk in Washington with USAID and those kinds of folks, they definitely, there were certain messages that resonated and certain things that just sort of fell on deaf ears. And in connecting it to HIV, the biggest sort of message that resonated is we, as the United States, has invested as more than any other country in global health. It's been primarily focused on HIV and maternal and child health, and we're going to lose that investment if we don't then extend it to, that whole group is going to kind of fall to other diseases if we don't make it a broader mandate. And that, we were talking with him in New York, and he said that over any other thing that he ever mentioned to anyone in Washington, that was when people sort of looked up and said, oh, okay. Washington, like there's different kind of pockets for advocacy. The group of people that are doing NCD advocacy in Washington with USAID and those sort of folks, they have a really set sort of talking points that broadly, just in general, absolutely, there should be more people kind of on all levels, from civil society, from governments themselves, from ministries of health. There needs to be kind of more of a cry for NCDs and cancer, and whether that comes from kind of patient advocates or different, there's definitely the need for that. Some of the work that we're doing is we just launched a Lancet Commission, which will be kind of through Harvard, looking at NCDs and poverty. And so we're kind of one piece of a much larger issue, but we're kind of looking into what's needed to raise that alarm for settings of extreme poverty and NCDs. And so there's a working group as part of the larger group of researchers and trying to connect it with advocates and sort of build the movement on poverty. There's great work with the NCD Alliance and generally doing that, but
You know, it's interesting, I remember someone telling me once that for a senator or a congressman to get 10 letters on a particular subject was like a real attention getter. And I thought, 10 letters? How hard would it be to get 10 letters together? 10 handwritten letters, not emails. And I think, you know, write your congressman, write your senator, get 4 or 5 friends to get 1 or 2 friends, and the next thing you know, you've got them paying attention to this issue. Now, whether that individual person, you know, can do it, you know, that's going to take a while. But we have these tools now called Facebook and Twitter and so on, which have been force multipliers. They're also major distractors. But to get messages out, we have all these tools, GoFundMe and Kickstarter and all kinds of things. So, and you all know how to use those things way better than, well, this part of we, anyway, does. So, you know, I think just be aware that like 10 letters on a subject is going to get the attention of a senator. That's it. I think that's an interesting thing, that 10 letters, probably from constituents, and voters preferably, and actually you should all be voters. Hello, voting, very important this year more than ever. I don't know if you've noticed what's happening out there. I won't say more, but somewhat troubling.
I think in the academic space, I think students also have more kind of power than they think they do in terms of, you know, BU for the BU School of Public Health. I mean, there was a really great NCD class that I took with Susie and a new professor who had come in, Veronica Wirtz, right when I started in the department. But for the most part, there wasn't a lot going on in NCDs. There definitely wasn't anything going on in global cancer. I got involved with GO because I skipped a lecture to go attend a Paul Farmer talk when they
With
were
permission.
announcing the initiative. It was epi, so it didn't matter. It was fine. But I went and I got involved and I got on the kind of volunteer list right at the very beginning of GO. And was kind of in my classes the annoying person who always talked about cancer and NCDs. But now there's a BU chapter of Global Oncology Young Professionals at the BU School of Public Health in Madison, and there's a number of us who kind of started to all realize we had a shared interest and all doing stuff with GO or doing stuff in global cancer. One of my peers is now at National Cancer Institute working on a fellowship there. And that was largely the story over at Harvard, where it was a lot of students who...
Yeah, I mean, I think that we started GO because we thought that at the time there were no training or research opportunities for fellows in the program to really address this issue. And so we saw that as a need. And what we really realized over time was that it was really going to be the students, the trainees that we were mentoring that would really lead the call here. And I think that's among the people in the audience. And I think that, so there's a great opportunity and a great moment here, both in the global health agenda due to NCDs and the work that Maia is doing and others, to really advocate for putting global cancer and global cancer control at the top of the agenda.
I guess that brings us to 1:30 and conclusion of our session. I want to thank our panelists. Thank you very, very much, Maia and Franklin. It was really great. Thanks to the Pardee Center for organizing and hosting the seminar. And thank you all for attending. Oh, and perhaps Mr. Pardee himself is watching. If so, let me thank you for the Pardee Center.
Yes.
If you are there, thank you so much. And thank you all for attending. Thanks to 450. Glad to see you, and I hope you enjoyed your session today. So, and then you'll probably be able to find out more about the Pardee Center on the website and about any upcoming events you might like to attend. Thank you for coming.